joining us tonight. This is part 2 of the sort of recovery from COVID, really, story. Sarah Biffin, our Chief Operating Officer, very kindly gave us an update in November, and she's joined today. So, Sarah, you can see on your screen, and she's joined today by Lisa Challoner, who is our Divisional Director of Surgery, Anaesthetics, Cancer and Critical Care. So she has the longest title in the trust. What we will do is we will run the presentation. It's quite a long presentation, so a lot of information in it. If you have any questions, I suggest that you put your hand up or put the question in the chat, and we will take it as we go along, because, as I say, there's a lot of information. And I will ask everyone, I think you all have got your microphones off because we get back feed. And from my team tonight, we've also got Hannah Morris, who's my Head of Public Participation, and Kate Ballinger, who's our Community Engagement Facilitator. And I'm Julia Clark, I'm the Director of Public Participation. So thank you all very much indeed. Kate is going to do the honours and run the slides for us tonight. And as I say, if you have any questions, please raise your hand or put them in the chat. Thank you. Over to you, Sarah.
Thank you. Thanks, Julia. So as Julia said, I did this a presentation with regards to our recovery from COVID in November last year, and I just wanted to update on where we've got to in terms of our recovery to date. And as everybody knows, COVID was, we closed down most of our services during COVID, apart from our urgent care. And so it's been a long time how we're trying to recover this now. So if we move on to, so what I wanted to cover off today in this is talk. So next slide, please. Sound like I'm important. So I wanted to cover off urgent and emergency care. So where we are with urgent and emergency care, cancer and planned surgery recovery. So some of our key headlines. Our outpatient transformation programme, so to how we're improving our utilisation of theatres and outpatients, something about diagnostics and obviously theatre utilisation, as I talked about. So next slide, please. Oh, and the next one, please. Thank you. So we pulled together an urgent and emergency care improvement programme work stream over the last 12 months, which concentrated on, as you can see, these 8 areas that I've got on the slide deck. And so if I just take you through them in no particular order, but if I start in the top left-hand corner, we established an acute floor on the RSH site because we recognised that we didn't have an acute floor that could receive GP and emergency patients. We had a very small department which would only have 20 beds, but we recognised that we needed something much bigger. So we pulled together a capital programme and we established this acute floor. We went through all of the building programme, and we were pleased to say that on the 19th of December last year, we were able to open up the acute floor. And since opening the acute floor, 3,096 patients have been treated through that floor. 2,083 of those patients would have previously been through our A&E department. So that's where they would have been seen during COVID and after COVID. So that's obviously freed up some capacity within our A&E department to see those urgent patients via 999. 23% of those patients were discharged home directly from the acute floor, which is great. So they came in, they had treatment, and they were discharged home on the same day. So that's really good. And we pulled 735 patients who came into A&E. They were then pulled from A&E up into the acute floor. So that's really been a success story for us here in SAP, and particularly on the RSH site. We've also improved our discharge facilities. So we recognised that our patients were not being discharged in a timely way. So what we needed to do first and foremost was to have a facility that would enable us to discharge patients into what we call a discharge lounge, so that we could free up bed capacity in the trust. So we've used our utilisation of our discharge lounge has increased with a greater proportion of moves earlier in the day. So 22% of our patients are discharged before midday now. And then obviously 70% of our patients are discharged before 5 o'clock, which is great for our patients to be home sooner. We now have a discharge lounge that is open at 7:30 in the morning, so patients can go into the discharge lounge to have breakfast and wait for their transport in there. And we've also created an additional discharge lounge space at PRH. So we've now got a seated area and a bedded area in PRH, which is affording us some more capacity. So that's really, really good for our patients. As I talk about discharges, we wanted to improve our ward processes because we recognised that those weren't where we needed them to be. So each medical ward on either site has got an improvement plan now, so that they work together with the nursing team, the doctors, the physios and OTs to be able to make sure that our patients are discharged home. And so we've reduced the number of patients who have been in our hospitals, which are over 14 and over 21 days. So that's really great. So we're getting patients home much quicker. And we've also improved the use of our virtual ward. So patients are able to go home, but with support from our community colleagues. So our district nurses and our virtual ward team. So they're able to go home and be treated in their own home much sooner than they would have been. So that's in its early stages, but we're seeing some really good improvement with that one as well. We've also created what we call direct access pathways, so patients who can go directly to an area rather than going through ED. So we've created an oncology assessment area open on Ward 23. So that opened up this year. So that's really good news for those patients who really shouldn't be going through our A&E department, or if they do go through our A&E department, we're able to pull them up into that space very quickly. And we've also created a trauma assessment, we piloted a trauma assessment unit on Ward 31 on the RSH site. Again, those patients who present in A&E but very quickly can get to the right place as a trauma assessment area. So definitely some good work that's happened. What we also put on and we do this with our multi-agency, it's what we call a multi-agency discharge event. So that's working with our partners across the system. So Shropshire Community Hospital colleagues, our local authority colleagues, including social workers. And we learn from those events about what is stopping patients going home and how can we get patients home much quicker. So we've now implemented what we call a live daily tracker. So every patient in our hospital is tracked through their pathway. So they're ensuring that we don't have any waste, and so that we're able to unblock any blockages for preventing them from going home, whether that be a diagnostic test that they require or they need some equipment to go home. We track that through this process. And we also, through our MAID event, recognised that we weren't utilising the virtual ward as much as we could do. And so as a result of that, we did 2 weeks with our agents, with our partners, to look at what was stopping people going home on virtual, what was stopping our patients going home on the virtual ward. So that's been really successful, and we've been able to improve the number of patients that are stepping down onto the virtual ward, which is good for them, and that's what they want to do. We've also reconfigured our emergency department and to try and reduce our ambulance delays. And I can say that although we haven't eliminated delays, we've still got delays for ambulance offload. We've significantly improved over the last 6 months, since October, actually, we've improved our offload delays. Still not where we need them to be, still not within 15 minutes, which is the national standard, but certainly much lower than they were. We were having patients waiting for 4 or 5 hours in ambulances. That we don't see those numbers anymore, and so that's really good. And what we've created is ambulance receiving areas, and those ambulance receiving areas are run by our nursing staff, our medical staff and paramedics, so we're all jointly working together. And so the RSH one was opened in November 22 and the PRH one was opened in April, and we've seen lots of success in those 2 areas. And what we've also done is we've recognised that our emergency care departments, so both our A&Es, we need to do some further work on how they are working, how they're structured, etc. And so we've established 5 work streams within that emergency care transformation programme, where we're improving the culture of the department, we're improving the pathways, so that we ensure that we've got the best, we were trying to work towards having the best A&E departments, or better than they're functioning at the moment. So yeah, so that's the work that we've been doing in the urgent and emergency care improvement programme work stream. Next slide, please. So if we just go on to, obviously in COVID, as I said, we stopped seeing outpatients and we stopped doing diagnostics because obviously we had to concentrate on COVID and treating our patients in COVID. So this is just a few key headlines in terms of our cancer elective recovery programme, or what we call planned surgery. So next slide, please. So some of the targets that are in the operational plan, which is set for us by the NHS, is that we were to eliminate patients waiting over 104 weeks. So patients waiting 2 years for surgery or for treatment. So I'm pleased to say that we don't have anybody waiting over 104 weeks. And so our May end position was 0, and our June position is forecast, which is tomorrow, the end of June, is forecast to be 0 too. So that's really good news for our patients. The next standard or target that the government or the NHS set to us was 78 weeks. So obviously reducing those waiting lists from 104 weeks down to 78 weeks and then down to 65 weeks at the end of March 24. So at the end of May, we had 73 patients waiting against a forecast position of 77. And also I'm pleased to say that we were able to open up elective orthopaedics on ward 36 at PRH, because if those people who were here at the previous talk in November recognise that we hadn't restarted elective orthopaedics on the PRH site. And so we are pleased to say that we have restarted elective orthopaedics at the Princess Royal Hospital, and we are maintaining that service. So we have a ring fence ward for elective orthopaedics, and that's been open since the middle of March. I just pick up on cancer. Obviously, cancer is really important, and that standard is really important to us. And so what we're trying to do is to eliminate or reduce the number of patients who are waiting over 62 days. So I can say that we are significantly improving that target. And as of June, we've significantly, at the end of May, we had 431 against a monthly trajectory of 468. But again, at the 11th of June, it was down to 407. So not where we need it to be. Our target set for us for the end of March is 212, but clearly we want, if we can get better than 212, then we will do so, because obviously this is a really important target for us. Also, what patients who have waited 104 days for treatment, we've reduced that backlog from 134 to 108. Against a monthly trajectory of 162. So again, we are improving that every week on week. We have some challenge specialties or challenge tumour sites, as we call them. So colorectal cancer, gynae cancer and urology cancer. So big numbers of referrals that we get into that service. But we're really working closely with our system partners and the regional NHS regional team to improve that service that we offer. We're piloting a teledermatology pilot, and we've targeted that with the primary care networks, so to improve the 2-week wait pathway for skin, for dermatology. And also patients who are referred on a colorectal pathway, again, we're working with our system partners so that they have the appropriate test and they're referred into us with that appropriate test for colorectal. For patients with prostate cancer, we're obviously got additional reporting so that we can diagnose their cancer much quickly if they have cancer, or eliminate or take them off the pathway and give them the good news if they haven't got cancer. So we're working with our teams on those. So those are real challenge specialties at the moment, and they continue to be a challenge across the West Midlands, certainly, and nationally. These are the known challenge specialties. So urology, particularly, gynecology and colorectal. So we're not out with everywhere in the country for these challenges. So from a diagnostic perspective, so this is about our CT scans, MRI scans, ultrasound scans. Our turnaround times are improving considerably. We're not yet meeting the standard for less than 10 days from scan to report, but we are certainly getting much better. And we've had, if you visit the hospital at all, you'll see that we've got additional mobile CT scanners on site at both PRH and RSH, and we've got that reporting capacity in place now. So when you come for those scans, the reporting should be much quicker to get the result of that scan than we have previously been able to achieve. So that's really good news for us. Next slide, please. So if I talk about, those are the key headlines for cancer. So if I just go into a little bit more detail, so next slide. please. So one of the standards that is set for us, and this is one of the standards that we're really working hard on as a team, is faster diagnosis. So what we've said is that every patient, and this is a national standard, every patient must receive a diagnosis within 28 days, whether that diagnosis is they have cancer or they do not have cancer, and each patient must be told that they have or they haven't got cancer, and then we go along a different pathway if they haven't, and we can carry on cancer pathway if they have. So clearly the target set for us with this is that 75% of patients should be told within 28 days that they do or do not have cancer, because there's nothing worse than being on a cancer pathway and therefore then not being told the results or having to wait for the results. So it's really a really important target for us. As you can see from the slide deck, our unvalidated position at the end of May is 62.5 against a trajectory of 63.2. So just under where we need to be. And there are some key milestones in this target. So there's a milestone at the end of June, a milestone at the end of September, and then a milestone at the end of March. So those are the key milestones that we need to achieve. So we've obviously worked with each of the tumour sites to ensure that we've got the right process in place, that these patients are able to, we're able to deliver the right care for these patients and obviously tell them if they haven't or haven't got cancer. So this is a really important standard to us and one that we are working hard with our teams on. Next slide, please. So as I've talked about our 62-day backlog for all tumour sites, so I've said that obviously our target is our revised recovery trajectory. So our target set to us is 212, which is set for us by the regional NHS team. We have got a trajectory that will take us to lower than that, 202. And if we can get lower than that, we absolutely will. But we will deliver the 212. We'll get lower at the 202. And obviously, if we can improve that further, that is what we are going to do. And each of those tumour sites, as I've talked about, so colorectal, urology, gynae, breast, all of the tumour sites have improvement plans which underpin the delivery of this target. So each of those, so if we go to next slide, please, I think so we've just given just a snapshot of where we were on the 11th of June. So as I've said, our backlog and how we're seeing the improvement. So it was at 460, it then went down to 407, and it's lower than that now. But we're just giving you some information that we are really improving the number of patients that have waited over 62 days. So that's really good for our patients. Don't know if there's somebody got their hand up. Sorry. Know if there's anybody who's wanted to ask a question on that. No, okay. Thank you. Sorry.
Sorry, Sarah. No, I can't see a hand up. I think there was, but I think it's gone down.
Okay, thank you. So obviously I've talked about the fit test. So basically a fit test is where you test if it's basically testing poo, isn't it, to see if patients have cancer. And so what we're encouraging our GPs to do is to, when they refer a patient in, is to ensure that they do that fit test first before they refer the patient in. And then obviously, if that fit test is negative, then obviously we don't have to do all of the invasive procedures that those patients may have to undertake if they are on a cancer pathway. So it's obviously freeing up capacity for us then to enable us to treat those patients who we do suspect who have cancer. So it's really important that our GP colleagues ensure that when they make a referral into our service for colorectal cancer or suspected colorectal cancer, that each of those patients are referred in with a fit test. Okay, and then what we're working on as well with teams from the University Hospital North Midlands is that we can pull together a non-specific site cancer pathway. So those patients who we don't think have got colorectal cancer, but we're really concerned about because they have symptoms, that we can refer them in on this pathway. And so we're working with a consultant at University Hospital North Midlands to be able to work with us so that we can offer that service. So it was obviously collaborative working across the network and also collaborative working within our local system as well. So next slide, please. So these are just a few slides. I won't go into all of the detail because there's lots of detail behind all of these, but this is just to show that we do have a recovery trajectory for every one of our tumour sites. So this is just giving you one for urology, which I've talked about being one of our challenge tumour sites, obviously because the significant number of referrals that we get into this service every day and every week. And so obviously ensuring that we've got the right capacity in the right place to treat the patients within the timescale. And particularly, as I said, focusing in on that 28-day faster diagnosis, which is where it really is we're focusing our effort this year. Obviously, we want to reduce the backlog, and that's what we're doing, and you can see that we've improved on that. But obviously, that faster diagnosis is the one that where we're really focusing our efforts. Next slide, please. And again, the same for gynecology. So, and I'll just point out that what we're as an organisation, we're classed as being in a tier 1 category for our cancer performance, because it's not where it needs to be in terms of our backlog and not where it needs to be with our faster diagnosis. So that means we get support from NHS England, from our regional team, in order to be able to help us to improve, whether that's the outpatient pathway or whether that's the diagnostic pathway, to help us to improve this target. So we've had some support, whether that be money or whether that be people, to help us to get along this trajectory. So it's really important that my ambition for SATH as an organisation is that we exit that tier 1 support and we're able to maintain and sustain this service within SATH without the external support. But it's very well received in terms of the support that we're receiving at the moment. So if I move on to the next slide, please. And so again, same slide, and obviously these slides will be made available to everyone. It's again for 62-day backlog and our faster diagnosis recovery trajectory. So all of the work that we're doing, both internally within SATH, across the system and with the regional team, in order to make sure that we deliver this standard for our patients and the population that we serve. Next slide, please. Oh, next one, please. Sorry. Okay, and just some information, as I've talked about, obviously we've got patients waiting longer than we want them to, so 104 days. So again, we've got a trajectory to deliver a reduction of over 50%, and so again we've got a trajectory there that you can see where we are in terms of our performance. So again, ahead of where our trajectory, and obviously we will never eliminate 104 days, like you'll never eliminate all of the backlog, because there are complex patients that wouldn't able to go through a pathway within the target set. And that's why the target is 85% for 62 days. And it's, you know, so that's the reason why there, because it's obviously complex patients can't always go through within the time set, because obviously they have several diagnostics and interventions at parts in their pathway. So that's why it's not 100%. Next slide, please. Okay, next slide. So this is one about elective recovery. So those patients who are waiting for a routine procedure, routine operation. So I've talked a little bit about this in terms of we're really pleased that we don't have any patients waiting over 104 weeks. We do have patients who are waiting for cornea transplants, but obviously, Lisa, I don't know whether you want to come in on cornea in terms of the reasons why we can't deliver.
So there's a national shortage of graft material, which we report nationally, and there's a database now that prioritises the graft material in terms of longest wait. So that's why we've got an issue with graft material. But that is looked on a daily basis, and we do report that to NHS England. And like I said, they have a prioritisation system for those longest waiters to ensure they're treated in a timely manner.
Yeah, so this is managed nationally. So it's not managed by us within SATH. It's managed nationally, because obviously, as Lisa said, there is that national shortage of the graft material to be able to do that procedure. So all of our patients are in a waiting list that's a national waiting list, and obviously they get treated in both clinical priority order and then waiting time order as well. So that sits outside of SATH, unfortunately, at this stage. 78 weeks I've talked about, so I've talked about the reasons why. I mean, clearly 78 weeks has been impacted, and we all have seen it in the news, and we're impacted by junior doctors' strikes. So obviously that has an impact on our ability to deliver all of the care that we need to deliver, when obviously we're short of staff to do it whilst they're striking. So obviously that has an impact on the delivery, but we try to minimise that as long waits. So we try it doesn't impact on 78 weeks as much as possible, because obviously we want patients have been waiting long enough, and to be cancelled as a result of not having the capacity is not great. So we're managing that, and we manage every patient on an individual basis. So obviously the strikes in June didn't help us with that, and obviously we've got more strikes happening in July. So again, we try to manage that, and I say every patient we manage on an individual basis, so that we're ensuring that we don't as much as possible try to not cancel long waiting patients where we can. What we have got access to is digital mutual aid system. So those patients that we can't treat within those timescales, so 78 weeks, we can put those patients, we can speak to those patients and ask them if they would like to travel somewhere else, if somewhere else has got the capacity. And what we do is we put those patients onto a database, and then those are looked at by all of the providers or hospitals within the region or outside of the region, and if they've got capacity, they will contact us and they will let us know whether they can treat our patients. Clearly it's patient choice, so the patient has the choice whether they want to travel or not, but obviously we speak to the patients about that anyway. So it's you don't have to, it's something that we speak to the patients about. But we have sent quite, lots of patients have chosen to have their procedures elsewhere if we haven't got the capacity internally within SAF. But what we're trying to do is to create that capacity. So all of the work and all of the improvement we're doing, particularly with our emergency care pathway, is to ensure that we have the right beds available so that we're able to admit these patients on our elective pathway. So yeah, that's what we're doing at the moment in terms of that, but that facility is available to patients should they wish to travel. Next slide, please. Okay, so what we've got now is what we've got 65 weeks is what our 65, we should, the national target is no patient waiting over 65 weeks by the end of March 2024. So we monitor this on a weekly basis, and I'm pleased to say that we're ahead of our trajectory in terms of our overall number of patients waiting over 65 weeks. So we've clearly reduced that significantly since April 2023. We've reduced that significantly. And then we set ourselves a monthly target as well. So where do we want to be at the end of June? Where do we want to be at the end of July? Clearly, this is again challenged by some of the stuff that's going on nationally in terms of strikes. But we work, as I said previously, we work hard to try and eliminate cancelling patients that have had their surgery booked and they're waiting 65 weeks. So we do have some challenge specialties still remaining, and so I've talked about urology being a challenge specialty in terms of cancer. It's also a challenge specialty in terms of planned care, so routine care as well, but we're working really hard with our consultants to improve that. Orthopaedics is also a challenge because, as we've said, we only restarted elective orthopaedics back in March this year, so we've clearly got a backlog of patients that we need to treat, and so we're again working with our surgical teams to improve that. We have small number of patients or small limited capacity in ear, nose and throat, but again, our doctors are working with us on this. And some of the medical specialties, so respiratory and cardiology, again, those are national challenges. So it's not just unique to SAF, they are national problems in terms of being able to treat patients within 65 weeks. But obviously, we have a trajectory that gets us down to 0. So as long as we continue along that trajectory, we should be able to see all of those patients by the end of March 2024. Next slide, please. Oh, it's stuck.
I think sometimes it's just a little bit. While we're waiting, Sarah, can I just ask what modality LLB stands for?
That's a company, an outsourcing company that we send.
All right.
Yeah,
So they're a private company that
they're a
we
private
send
company.
patients
Yeah,
to.
yeah.
Thank you
Yeah.
very much.
Thank you. So I'm going to hand over to Lisa on outpatient transformation, because this is the work that she's been doing on outpatient transformation. So next slide, please. We'll swap seats.
So we've been doing a lot of work around outpatient transformation. So we've got a number of targets we need to achieve to improve our capacity and ensure patients are treated. So obviously ensuring patients in a timely, safe and effective, sustainable care. So right location, right time, right person. And we've done a lot of integrated work with our primary care colleagues. So one of the targets we've got to is about patient-initiated follow-up. So our current target is 5%. So this is where a patient who needs to be followed up or needs some form of access into the system is placed on a patient-initiated follow-up by their consultant following their consultation. This allows them to be put on a PIFU, and if they need to be seen for a follow-up within a period of time, that gives them access back into the system. We're currently at 1.8% as of September 22, but we've made significant progress since then, and we're currently at about 3%. Virtual consultations, so that's where patients are seen virtually, either through media or via telephone. So instead of coming into the hospital setting, you can be seen through various forms of media. Advice and guidance, which is advice and guidance. This is where the GP refers a patient into one of our clinical centres for advice on their treatments, as opposed to being referred into the hospital. So our consultants feed back with some guidance to the GPs as to how they can be treated or whether they need to be seen. This obviously allows us to optimise referrals and reduce outpatient first waiting attendances. Next slide, please. Obviously, in terms of PIFU, this is monitored on a weekly basis, and we have a number of specialties to present. We also a system target with the Shropshire Telford and Wrekin Trust. So this just gives you an indication of how we're doing against that target. Next slide, please. Obviously, virtual, as we talked about, oh, sorry, one forward to Mary Kate, sorry, thank you. So virtual is where patients are seen virtually. So opposed to coming to the hospital setting, you can have a telephone via telephone conversation or via virtual media with your clinical colleague or clinical centre that you're under. This avoids unnecessarily, in some respects, appointments into the hospital, visits to the hospital. And a lot of our patients do like the virtual setting where appropriate. It's not appropriate for all specialties, but where appropriate, it is really liked by patients. Next slide, please. Oh,
thank you. So this is our diagnostic slide. So what we have another standard as part of the operational plan. So it's called DMO1. So this is our recovery of our diagnostic standard. So that could be a CT scan, an MRI scan, an ultrasound scan, access to endoscopy, or access to echocardiography and cardiology. So the recovery target for this year is 85% compliance for all modalities, including endoscopy and physiological measurement. There is a national focus on reduction of patients waiting over 13 weeks, with the ambition that this will be reduced by 0 by March 2024. So our trajectories indicate that this will be delivered in all modalities, with the exception of endoscopy. And what we're doing at the moment is we're working with our West Midlands Cancer Alliance colleagues to see how we can improve the capacity, or increase the capacity we've got available to us for endoscopy, so that we are able to meet this standard. But I can see, if you look on the right hand side of the slide.
Next slide, Kate, sorry.
Oh, sorry, next slide, Kate, sorry. So if you look on the right hand side, so recognising that the standard for 23-24 is 85%. So you can see from an MRI perspective, so it's seen within 6 weeks, 89.4%, and April was seen within 6 weeks, which is good. CT, 97.4% of patients were seen within 6 weeks. Ultrasound, we've still got some work to do with ultrasound in terms of it's 66.6% of patients were seen within 6 weeks, and we've got some additional capacity coming online in July so that we can improve that target further. As I've talked about, we're working with our West Midlands Cancer Alliance colleagues to see how we can improve our endoscopy target. And obviously, as I said before, we're in a tier 1 with the NHS, a regional NHS team. So they're supporting us with how we deliver that. And with our echo, we are at 95%. So we've made some significant. So when I presented this in November last year, we were nowhere near these numbers and these percentages. So there's been some really, really good work that the team have done. But not only is diagnostics about having your test, it's also about reporting your tests. So our reporting times in November were out to 14, 15 weeks. So not only had you got to wait a long time for your test, but you then had to wait a long time for it to be reported. I can actually say that we're just over 10 days for reporting now. So some significant improvement in terms of our diagnostics that we've done over the last sort of 6-8 months. Next slide, please. So again, theatre utilisation, and this is again within Lisa's area. So if you pick this up, Lisa, in terms of our theatre productivity. The next slide, please.
So obviously we had some significant workforce challenges within theatres following COVID. We had a lot of experienced staff leave our theatre areas, either retirement or moved on. So we've had some challenges with staffing, but we've pulled together a trajectory in terms of improving that. It's a daily task we do. We've also got a clinical lead who supports with theatre utilisation. This is about optimising our theatre so we can treat as many patients as possible, working with our clinical teams and our ops teams about how we ensure those lists are full. So we've got a trajectory, as you can see, and that's monitored on a monthly, daily basis. So our trajectory, this is linked to staffing as well. The national target is 85%, and as you can see, we are on an upward trajectory now to achieve. But it is difficult in terms of our staffing. But we've got a number of staff we've appointed into our theatre complex who require training, so that is an improving picture for us for theatres.
Yeah, so what we've got is again a national target for us that we our theatres must be 85% utilised. All theatre lists that we put on must be utilised 85%. Clearly that's the standard. We want to achieve more than the standard of 85%. But as Lisa said, we've had some workforce challenges within that area because obviously during COVID we didn't do that much operating, so people did leave or they did retire, and so we're just, as Lisa says, we're on that trajectory of workforce and a different workforce model. So we're looking at apprenticeships for our staff. So not just the traditional nursing model or operating department practitioner model, but also looking at those apprentices as nursing associates so that we can make sure that we've got a sustainable service. And obviously, as Lisa said, we do want to improve the utilisation of our theatres, because the more that we can improve the utilisation of our theatres, the more patients we can treat, and therefore reducing our backlog of patients waiting. So it's really important to us that we deliver this theatre productivity programme of work that we've pulled together. And again, we are supported by NHSE in terms of information and best practice and how we can deliver differently. And as Lisa says, we've also appointed a clinical lead, one of our surgeons, who will be working alongside us to ensure that our theatre lists start on time, they finish on time, the session time is utilised to its full capacity, and we meeting with each of the specialties to ensure that we have a programme of work that will deliver that for us. So it's really important, this one, to us as well.
And theatre staffing nationally is an issue, so we're in a similar position to other trusts, but like I say, working really hard. We've done some next slide, sorry, Kate. So obviously in terms of our theatre workforce, we've introduced a theatre lead for safety and governance across both sites, and we've also introduced a theatre lead for education. So we've got a number of staff who've never worked in a theatre environment before, nurses who'd like to work in theatre. So we've got a targeted education plan to ensure A, that they are competent, and B, they've got the skills to be able to support our surgeons. We're also adopted a grow your own. So we've got a number of ODPs, operating department practitioners, on an apprenticeship programme. We're in our year 3 now, and it's been a really successful programme. at our recent recruitment event, we recruited 8 new registered nurses, and they've obviously got a package of support around them to develop and make sure they've got the experience to work in theatres. We've done a number of cultural sessions around governance to obviously look at our behaviours and values within there. We've got a framework around that. And we're also doing a number of theatre away days to promote staff wellbeing. We had a recent CQC and a mock visit, which was very positive. The National Theatre Lead has also been in to support us with some of our theatres. Patient feedback satisfaction service in place to understand what the patient's experience is like through theatres. And we've obviously opened wards 36 recently for elective orthopaedics, which is a dedicated ring-fenced area. We're not doing as much orthopaedics as we'd like to, but that is linked to theatre staffing, but that is an improving picture. Next slide, Kate, please.
So in terms of next steps, so what we've got on the what we're working on now is that we've got an elective day case hub that will open, that's being built at the moment on the Princess Royal Hospital site, which will open to patients from January. So January 2024, this is a dedicated ring-fenced area on the Princess Royal Hospital site, which will enable us to operate 52 weeks of the year, because previously, as I've said in the previous presentation in November, is that our day case unit on the PRH site is escalated into because of the medical emergencies that we're receiving. So this will enable us, this area, to be ring fenced so that we do not ever cancel patients because we don't have the beds available. So we're able to continue operating all year round, whereas before we tend to stop operating in November because of the winter pressures and restart operating April or May the following year. So we'd have 5 to 6 months of downtime where patients weren't being treated. So this is really good news for us that we're able to have this facility. We're going to be opening up our community diagnostic centre from October. The community diagnostic centre is in Hollinswood House in Telford, which is on the Stafford Park estate. So this will enable us to do CT, MRI, and also within that area as well, within the diagnostic centre, we will have renal dialysis off-site, which will be from October, November time, so that we will move the facility from the Princess Royal Hospital site into this purpose-built unit for our renal patients. So there'll be the low risk patients that will be treated in that area. So that's some really good news, because what that also enables us to do is to free up really vital bed capacity that we require. So the renal dialysis unit on the PRH site occupies a ward area. So what we're doing as part of our reconfiguration work that we're doing as SAP is that we will put that back to being a ward, and that will then become the elective orthopaedic ward, so that we're able to again ring fence that area to enable us to do more elective orthopaedics, because we'll have appointed the workforce to be able to open up the extra theatres, and we'll also have the bed capacity to enable us to be able to deliver more care for our orthopaedic patients. So that's some really good news in terms of the next steps. So that's the presentation in a whistle-stop presentation in terms of what we've been doing here at SAP to improve obviously patient experience and to reduce our long waits. Obviously COVID hit everyone really hard in terms of cancelling elective activity, but we're now on a trajectory of improvement and hope to see further improvements as we move from 65 weeks into a 52 weeks in 24-25. So we'll gradually get back to what was an 18-week target previously, but obviously slowly getting back to where we were. So thank you.
That's great, Sarah and Lisa. Thank you very much. A lot of information to take in. As I said to one of the audience, that this will be on our website, and I've put the link in the chat. But we have got time remaining, so well done for getting through all those slides. So I'll open it up if anybody's got any questions. While people are thinking about that, I've got a couple, if I might, please, Sarah. I mean, because I am sometimes director on call, I was very pleased to see that, is it now 22% of patients are discharged before midday?
Yes,
and 7% before 5 p.m, because that used to be about 4% if we were lucky. So that's amazing.
Yeah,
and
and it's helped us to have the extended day, the discharge lounge, because obviously we're able to have those discharge lounge. So patients, because what we also don't want is to patients to be discharged, go into the discharge lounge where appropriate. Some patients go directly home, they don't go to a discharge lounge, but those patients who are waiting for transport or their relatives to collect them, we've got a facility which is really comfortable that they can go into the discharge lounge. But we also have a target on that as well, which is not a national target, it's an internal target, so that we don't have patients waiting any longer than 4 hours in there. And obviously we want to bring that down further. So patients, so that we don't, you know, we don't just move a patient to the discharge lounge and that's where they stay. So we still strive to work with our transport partners to be able to ensure that our patients get home quicker than they were previously. So yeah, still lots of work to do, but we have made significant difference over the last 12 months.
Well, I know that some of our volunteers volunteer in the discharge lounge and have passed comment that it's getting a lot busier now. Before it used to be quiet until the afternoon. But that, you know, so that I think that's evidence, further evidence that, you know, that it is working. And the other point that I just wanted to was the numbers on the virtual ward. When the last time I was on call, I was astonished there's 150 people on the virtual ward, which was I don't think you mentioned the number, but that's, you know, that's like 4 wards, nearly 5 wards of people.
Yeah, so there's 2 parts to the virtual ward. There's step up, so and step down. So the step down are the patients who we step down from our wards into the virtual ward, into their own home. And there's nothing like going home, is there, and being treated in your own home. And then there's those that step up, so those patients who probably would have come to hospital but don't come to hospital because they can manage the patients on the virtual ward. So those patients who potentially would have come to A&E, they can know they don't need to because they can be managed on the virtual ward, or those patients who do come to A&E and potentially would have been admitted now can be stepped down or stepped up, stepped down onto the virtual ward. So there are, a lot of patients now that are able to be in that. So mainly we've got pathways for respiratory, cardiology and frailty, but we're obviously going to be working on other pathways as well going forward. But those are the 3 main pathways where we step patients down and up. So it's really good.
I remember many years ago, Jocelyn Briggs, who was one of our consultant geriatricians, saying that hospitals are very dangerous places for old people. So I think she'd be very pleased to see that we're doing all we can to support patients in their own homes, because that's, you know, that's got to be, it's very disorientating when you know, if you're confused anyway coming into hospital. So if we can support patients in their own home, that's excellent. Then finally from me, well, more or less finally, just a query on slide 19. You talked about patient-initiated follow-ups to account for 5% of all discharges by March 23. We've gone past that.
No, well, it was March. Yes, it was March. That was the target, March 23. That target has been rolled over to March 24, but the target was March 23. But so the target. So it's still 5%.
So before we put this up on the public website, I might change that, because if it's now 24, people are going to say, well, why aren't you reporting what you achieved if the target is now March 24? And the same with the 25% of all contacts. Has that been rolled over as well?
Yes.
March 24. And the advice and guidance, has that been rolled over?
All of those targets haven't changed, but
just for clarification, we'll just put in now March 24. Otherwise, people are going to say, well, that was 3 months ago. Why aren't you telling us? What you did?
So those are the only targets that didn't change in part of the operational plan. The rest obviously was 65 weeks for RTT, cancer and everything have all changed. And so, you know. But this one remained the same for the 2 years.
Well, we'll before we put it up, I'll just ask Kate or Hannah if they'll just sort of clarify that, because if somebody's reading that, they're going to think we're just behind the times. And then the final thing for me was really just about the theatre utilisation, because it sounds like it should be quite a simple thing to start when you should and finish when you should, but actually cases and surgeons are all different, aren't they? And what takes one surgeon 45 minutes to do might take another surgeon an hour and a quarter to do. So it's factoring in all of that so that you can maximize the number of cases, the number of people, but base it on what the individual surgeons kind of cases.
They are based on individuals, because as you say, not one surgeon can operate at the same speed as another surgeon, but there is sort of a benchmark where we expect the utilisation to be. I suppose what we want to concentrate on, isn't it, is those late starts, because it's that wasted time. We don't want our theatre listers to start late. So what we're doing is working with the lead surgeon who is working with us on this improvement to understand why people are starting late, and whether we can have staggered starts. So some people start earlier, some people start a bit later, but the time of the session is still, 4 hours. But we're working on different models, because not one size fits all, because there are, we're talking about health and well-being and commitment, pre-op and all the rest, and optimizing the patient. So so we're looking at all options available to us.
And some of the late starts, to be fair, have been linked to bed availability itself. Because we haven't had that dedicated unit from January will give us that space that patients will be seen in a timely manner, and then proceed to surgery. So bed availability has been a slight issue at Telford as well, which has affected our that time.
Because obviously we're escalated into the day surgery unit, which in other organisations is probably not. They've got a standalone day case unit, whereas ours is linked into the hospital, isn't it? So it does get escalated into. So by having this surgical hub at PRH will enable us to have that ring-fenced facility. And it's truly ring-fenced because it can't get a bed in there.
And a couple of other things that you haven't mentioned, but we've just introduced the Blue Spear theatre module. Is that going to help with
it helps with some elements of monitoring utilisation? Yeah, so that's a tool we can use. We can also put out average theatre times to ensure that lists are planned properly, so that will help. It's in development and it needs some further work, but yeah, absolutely will it give us some more information that we haven't already got.
It gives the daily and in the moment information. So if we have got an issue with late starts or early finishes, we can tackle it in the moment, because it's live. It's live information, whereas we didn't have that information before. We had to wait for a report to be produced, whereas this tells us exactly how long the surgeon's been operating, what time they started and finished, the anaesthetic time, any delays, anything. So we've got all of that information. So that's helping us to improve that utilisation.
And financially, that was quite a significant investment. And I think the other thing I just wanted to mention before I let Kate ask her question was about robotic surgery.
Oh yeah, so yes, we do have a robot.
We do a robot, yes.
We do have a robot, and at Shrewsbury, on the Shrewsbury site, which is great, because obviously lots of new surgeons today are trained on robots. So we're hoping to attract more surgeons, particularly urologists, because we have now offered that facility that other places have been able to offer for some 2 or 3 years. So we did our first operation, last Thursday for urology. So on the robot. So that was really successful, and we were just gonna speak to some of the patients on how that was for them, because obviously that's less invasive, so less time in hospital, getting home much quicker than they would be if they had an open procedure. So the laparoscopic or the robotic procedure is definitely reducing their length of stay. So only one so far. We're still got our surgeons training, but we will have a rollout plan for our gynecologists and our colorectal surgeons to be able to start that. So that will be in the next.
That'll help with our cancer pathways, avoid patients having to travel out of county.
Yeah, so patients have travelled out of county, particularly urology patients, have gone up to Stoke to have the procedure done robotically, or into Royal Wolverhampton. So now we can provide that service locally, which is great.
And we say only one, but how much do they cost?
Robots?
Yeah.
£1 million.
£1 million, yes. So
well, the average is £1 million, but then there's all the other stuff that goes with it, all the consumables, everything else, all the training for all of the staff, training of the nursing staff, the theatre staff, consultants, everything. So although buying the robot is probably the cheapest part, it's the rest that's wrapped around it that's really expensive.
Excellent.
But great for patients, because they don't have to stay in hospital for.
Absolutely. We might get an about health event about that at some point in the future, but Kate, you've got your hand up patiently waiting.
Amazing. And I didn't say a word either because I was listening to robots, and that just gets me going, because I think maybe a behind the scenes tour for the People's Academy. Shameless plug there. The reason I was just going to say, you mentioned about the development of the new operating theatres at Princess Royal, and I think, just for clarification, the new operating theatres are not being built in amongst the great big steel edifice at the front of the building. So that's creating the space to move the office staff out of the middle of the building into that space, so that the what was offices in the middle of the building can then become the operating theatres, which then will have the vacated renal dialysis ward directly opposite, won't they? Or nearly directly opposite. So it's the actual theatre provision is going to be inside the hospital. It's nothing to do with the building that's going on outside.
Building, no.
Yeah, no, it's just clarification, really.
What we'll also do with that vacated ward that will now be orthopaedics, there will also be a surgical admissions lounge. So our patients will just go directly into the surgical admissions lounge. They'll be seen by their surgeon and their anaesthetist, and then they'll walk to theatre.
Across the hall,
so it's just across the way, and so they'll walk to theatre, and it will be a much slicker process. So it's going to be.
As somebody
really
who's
exciting.
walked around hospitals with a theatre gown on, that will
Obviously,
be really welcome. If you don't have to walk down a long
dignity.
corridor with everybody walking behind you, that's
we're definitely not doing that. No, definitely lots of
and I think it's important to say that all of that aligns with the Hospital Transformation Programme, HTP. So all of this is sort of spending money now that won't have to come out of the 312 million to enable us to deliver the clinical model that is HTP. So it's all good news, really. Any questions from anybody else? Andrea.
Thank you. My question was on the patient-initiated follow-up. I noticed on the slide where you're talking about the targets, you'd got in brackets excludes Welsh patients or Welsh residents. Is that because the targets are different that Welsh Government and UK Government set? Or does it mean that you don't offer patient-initiated follow-up?
We offer the patient.
I thought so.
Yeah, absolutely. We don't.
I just wanted to check though.
It's just a national target that's only an English target, but we treat our Welsh patients in the same way that we treat English. We don't differentiate. So they're offered PIFU as well, even though it's not a target that's set by the Welsh Assembly Government.
And maybe
we probably need to probably make that a bit clearer.
Yeah, Andrea, that's a good point. Before we put the slides on the website, we might just clarify it's an English target, but we don't treat our Welsh patients any different. It's not a Welsh target, but we all treat all our patients the same.
We treat them the same.
Yes, thank you. And then I had another query on the endoscopy. That figure being quite low, is that because of workforce issues? Or what's the reason for that? And is SATH an outlier on that, or is it sort of common across the UK?
So it is linked to workforce, Andrea, yes, but endoscopy is a challenged area across the country in terms of capacity. Obviously, we prioritise our endoscopy in terms of cancer, urgent and routine. So, but workforce is a challenge across the region, unfortunately, across the country, unfortunately.
Endoscopy is and the demand for endoscopy has gone up 200% in terms of the requirements for patients to be on and have endoscopies. So we are. It is the workforce, and so we're just working on a business case to be able to. We've got the capacity in terms of the rooms, the endoscopy rooms, and they're fully equipped. What we haven't got is the workforce to support those. So we are using a company called 18 Weeks. Where we're insourcing, but that's only one room, so that's 7 days a week, one room. We've got another 2 rooms that we would have available to us, so we're just working on that to improve that. So again, as I said, working with West Midlands Cancer Alliance, who are supporting us with some of this as well.
And as Sarah said,
Thank you.
both endoscopy suites on both sites have recently been extended and modernised and upgraded. So the facilities are state of the art now, but it is the workforce. And we have nurse practitioners. We've done everything to develop it as much as we can, but now it's going to need, you know, a workforce injection, which Sarah and Lisa are working on. So watch this space, really.
Thank you.
You're very welcome.
Thank you.
Anybody else with any more questions? Otherwise, bang on time. I will thank you all very much indeed. A special thank you, Sarah and Lisa, and we'll make those couple of tweaks to the presentation. And I think we'll put the recording on as well, because I think actually the background information that you've given to the presentation is very helpful, and we'll be able to hear some of the questions as well, so it would clarify some of the points that people have made. So thank you all very much indeed, and I wish you all a very happy Thursday.
Yeah. Thank you.
Thank you.
Thank
Good night.
you.
Thanks.
Bye.
Bye.